Hi, this is Brian Kim. I'm going to share with you this case of a patient who came to find me. She's coming from out of town, and she is an unhappy laser cataract surgery patient with a Symfony lens. And she had her surgery about 5 to 6 months ago, and she's here because she is bitterly unhappy with her vision. And this is a simple case of the patient and the lens are just not compatible. The patient's brain cannot accept the technology, the lens optic technology. And obviously, when you have these rings on the lens, it can cause visual distortion and aberrations. Some people don't mind it and see great. Other people do. And so this is a case of a patient who's going to have a lens exchange. And she was myopic before, and she chose to have a near target with her vision with a monofocal lens. So go ahead and make my paracentesis incisions first on the right side and then the left side. And this is some intracameral epinephrine and then some dispersive viscoelastic to fill the anterior chamber. And you can see her incision here. It's probably like a 2-4 or something like that. And I'm going to make a 3mm incision, but I'm going to go deeper than her incision. And so I'm going to go deep to that first incision to make sure I don't intersect that incision. By doing it this way, you are able to more confidently achieve a self-sealing incision. If you intersect the original incision, then you'll have a higher risk of leakage of that incision. So this is a 25 gauge needle mounted with the dispersive viscoelastic. I first go bevel down, making sure I get underneath the rexus edge. I go bevel up. And then I go bevel down, and I'm just trying to push viscoelastic underneath the rexus edge. I switch to the cannula and do a little bit of the same. And that's really the hardest step in the beginning, to make sure you get underneath the rexus edge. In this case, again, it was about 5 or 6 months ago. There wasn't that much fibrosis in this case. Going now with a cohesive viscoelastic and going underneath with the needle, getting under the rexus edge and pushing that cohesive viscoelastic. And right here, I'm pushing that viscoelastic with the bevel pointed into that space. Switch to the cannula, and now I'm able to more confidently and effectively push that viscoelastic, dissecting the anterior and posterior capsule adhesions and going around 360 degrees. That's why utilizing the paracentesis incisions is very important. You want to be able to separate the anterior and posterior capsules, because remember, they're fused outside of where the optic is. By using the viscoelastic, you're able to visco separate the posterior capsule and anterior capsule from each other. Here I'm burping some viscoelastic from the chamber. Remember, you don't need all that viscoelastic in the chamber. You're just causing higher anterior chamber pressure for no reason. And so I'm pushing more viscoelastic, visco dissecting at the optic haptic junction. And as I do this, you can see the lens optic is now starting to move, showing that it's actually separated from the bag. I get underneath the lens and I push some more cohesive viscoelastic, pushing the posterior capsule back. And now this is a Sinskey hook. I'm going to very carefully just tease and pull the optic up. And you can see it's not tethered. The haptic is not tethered into the bag, which is nice. And then I'm getting around the haptic and basically tucking it and angling it so it's able to come out of the bag. Trying to get to the other side, just go and switch incisions, and that's really an important tip. If you have a bad angle, just switch incisions. So here I'm able to lift it up, but then I didn't get a good angle from there, and I go ahead and switch to the left side incision. I'm able to bend that haptic in, and now I have the entire optic as well as both haptics in the anterior chamber. And remember, I have a dollop of cohesive viscoelastic between the posterior capsule and the lens. And here are the MST micro forceps and scissors, the IOL holder. It has serrated teeth, which is in my left hand, and then the scissors in my right hand. So with the teeth closed, I lift the optic up with the scissor, grab it with the forceps, and then just getting a better grip as I cut. The scissor actually holds the lens too, and I'm getting a better grip. As I'm cutting, it effectively acts like a holder, and I'm able to re-grip with the IOL holder. So that's another tip. And you can see I'm turning the teeth sideways so I can see it better, but also it keeps the back end of that scissor away from the posterior capsule. Switch from the scissor to another forceps. These are smooth forceps, but that's fine. I use that to disengage the left side forceps from that lens because, again, it's gummy. And I turn my attention to the right side piece. And why is that? Because look, that haptic is bending away. And so it's better to go after the right side piece. You can see I'm able to lift it up away from that left side piece. And as I pull it out with the forceps, you use the left side forceps to shield the corneal endothelium to make sure that that lens doesn't bend and hit the corneal endothelium. So now, because of the orientation of that other haptic, I'm going to dial the lens 180 degrees. So I'm grabbing the optic cut end on the other side, and now the haptic is in the right orientation to come out. It kind of collapses on itself, and I use that left side forceps again to shield the corneal endothelium from that lens to make sure it doesn't hit the corneal endothelium as the lens is being collapsed through the wound as it comes out. So here, an atraumatic lens removal, bisecting the lens with micro instruments. Very easy, very systematic. Again, as you cut, make sure you turn the scissors sideways. Remember, the scissor actually grips the lens, so you can re-grab with the forceps as you go along. You want to make sure you don't accidentally cut the anterior capsule or posterior capsule. You turn the scissor sideways, which allows you to do that. And then you saw a two-headed technique on taking the lens out and protecting the corneal endothelium. So you saw I injected some cohesive viscoelastic to fill the bag, and this is a single piece acrylic lens, a monofocal lens. I go in with irrigation off, activate irrigation, making sure both haptics are off the optic, getting underneath the lens, tilting it 90 degrees clockwise, removing all the viscoelastic from within the bag, repositing the optic back. And in this case, I want to have the haptics oriented in the same orientation that it came. I'm just nudging the haptics where they were before. Same orientation, polishing underneath the rexus edge, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had laser cataract surgery. She had a Symfony lens. She was not happy with the vision. She did her research and found me and found that I do a lot of these surgeries. And so we went ahead and took that lens out. I talked to her about, presbyopia correction is dicey. You can try it again with a different lens, but there's a chance you won't be happy with that either. And she just said, phooey, it's okay. I just want to have good near vision. I do a lot of reading. I don't want to wear glasses to read with. I don't mind wearing glasses to drive. So I said, that's an easy decision. Let's go ahead with a monofocal lens. You saw the technique that I employed to very easily and safely and methodically executing that lens removal. I don't know if you noticed when I hydrated the incision there was a little bit of a funny gaping of the cornea just to the left side of my main incision, and that was an LRI. So that was, a patient must have had a femtosecond laser LRI. But you can see, because I made my main incision underneath the original incision, as I hydrated the incision, it was a good self-sealing incision. There was no leakage whatsoever. Again, you saw the techniques that I employed to carefully tease and mobilize that lens and free it from the capsular bag, using a two-handed technique, being able to cut the lens out, protecting the cornea as I take the lens out as well. And this patient did very well. Again, showing you a case of a lens exchange in the bag, two in the bag lens exchange from a Symfony lens to a monofocal lens. So I hope this was helpful to you, and I thank you for your attention.